everybody. My name is Amanda Johnson, and my research study is based on parents that are new to special education, and so my research is really geared towards an article, and so the article is entitled "My Understanding of Special Education: The Initial Parent Experience." So I really want to ground us into really what part of this larger picture I'm researching. So we have the Individuals with Disabilities Education Act, and within that we have a legal mandate of parent participation. Parents are to be an equal team member and help to develop their child's individual education plan. The reason that I chose new parents is that the research supports the fact that parents are experiencing quite the opposite of what the legal mandate is. They are experiencing that they don't feel like an equal team member, and they don't feel that they have the knowledge base that the school systems have. And the first 3 years of a student's career in special education are often difficult ones for parents to navigate. They are showing that they feel a confusion with the legal terminology, the technical language and the processes. And for this reason, I felt it was essential to look at and listen to the experiences and stories of those parents who are new to special education. This graph shows the increase in the number of students eligible for special education over the last 7 years. For this reason, you can just imagine all of the new parents, new being first 3 years into special education, and that's steadily increasing as well. So for my research article, I focused on 3 questions. My first question was, in what ways do parents of special education students learn about the Individuals with Disabilities Education Act? My second question is, in what ways do parents of special education students understand, articulate their procedural safeguard rights? We often call these parents' rights, and you'll see that I refer to it as parents' rights moving forward. My third question is, in what ways do parents of special education students perceive their role in the individual education plan? I really wanted to ground this in a rich body of research. And so looking at these specific questions, the research really backs moving forward, looking at new parents to special education. So when I did my literature review, I really found that parents perceive the need to be fully informed of their special education rights, of the processes, service options, and procedures so that they can make a fully informed decision. For one of my questions, I definitely wanted to know, how did they learn about the Individuals with Disabilities Education Act? And secondly, how did they learn and how are they able to articulate what their parents' rights were, or those procedural safeguards? Secondly, parents reported feeling an imbalance of knowledge. Again, I wanted to see what that felt like for new parents. Parents reported the need for unbiased information so that they didn't feel isolated or incompetent. I wanted to see if that existed with the new parents as well. The description of not understanding the extremely technical and specialized language that comes with special education, that too was looked at in my interview processes. And what I felt was interesting and I wanted to share with everybody is a survey that was conducted by Fish in 2008, in which he found that 44% of parents that were surveyed indicated that their special education understanding was obtained by educating themselves. Again, my questions are really geared to finding out if that is accurate in this area, and so I looked at Northern California. So I've talked a lot about the purpose and the reasons why, but I really just wanted to be clear and concise about the purpose of my research for you today. So the purpose of my research is to look at the lack of equity and training amongst IEP team members that results in the parent and school conflict. Through my research, I have seen that there is a dissonance that exists between the law, the current practice, and the understanding of that law, which is the Individuals with Disabilities Education Act. IDEA gives the expressed right that parental involvement is supposed to be there for that IEP process. And parents become an equal team member, which makes them fully informed so that they can have an adequate understanding of the law to make those fully informed decisions. The significance of my research, this is where my hopes come to. I really hope that this research will lend to our universities who are educating our future teachers, to policies that will allow the LEAs, which is our school districts and our county offices of education, our universities that are teaching our teachers and our parents to come together to bridge the gap that has been shown in research that exists. And I really hope to influence those programs moving forward. I chose narrative inquiry for my research. I feel that the thick, rich descriptions that are given through parent interviews, to listen to their experiences, to hear the way that they describe their perceptions of their experiences, their feelings, their thoughts, and the emotions that it evokes, it was really important to understand the issues that are presented within this research. And for that reason, I picked narrative inquiry. For my research participants, my research is focused on 5 parents. A parent is one. They had to have been the parent that attended the IEP meetings, who was present for all of those meetings and through the assessment process as well. They must be the educational rights holder, as is described within the Individuals with Disabilities Education Act. They also have to have not had any other children within the household who are on an IEP. They couldn't have been on an IEP themselves when they were children. So I'm really looking at parents who are absolutely new to that process. For the students on an IEP, we're looking at eligibility that was gained in kindergarten through 6th grade. The student had to have gone through the initial assessment, but has not gotten to the triennial assessment. And of course, they had to agree to participate. Okay, for data collection, this is broken into 2 separate interview processes. For the first process, I had a semi-structured interview protocol, and all interview processes were audio recorded. So through the semi-structured interview protocol, I was able to let the interview go in a naturalistic format. However, I did have probing questions to make sure that I stayed on track. So that was the first piece. I had a demographics form that was filled out, and through that first process, one of the questions allowed the participant to draw their IEP process. And so what I mean by that is the initial IEP meeting, I had asked them to draw that out. Can you draw the shape and size of the table? Can you indicate where each member sat? And so through this drawing process, I was able to ask them to walk me through that process, giving a visual guiding activity. And it helped to elicit a little bit more feeling and thought and emotion of that initial experience. Some of those experiences were new for the parents, and some of them had been a couple of years. And so this guiding practice helped to elicit what feelings and emotions they had felt when they walked into that room. I also conducted my own interview reflections after each interview. For the second part of my interview process, it was activity-based. So for this process, the first thing that you will see on the top right-hand corner of this slide is a timeline. So this is a basic question of, given what you know now, what would you have liked to have known during this process and this process and this process? And for this particular question, I'm really looking at what information was lacking. Given the information that you know now, what was lacking and what is the suggestion for having that information given to you then? How would you have liked to have had that information? The next activity is a hurdles and barriers with suggestions activities. And so this is getting to the point of a question, what was rough for you and how would it have been easier? How would you have liked that? And the last piece is a support system. Who was your support system and who supported your knowledge of IDEA? After the interviews, I transcribed them, I member checked them, and then I started my coding process. So for my coding process, I started with inductive coding. I did open coding to start with, so looking at what information had jumped out, what was significant in that, what was surprising, and I started with an open coding process. I then moved into combining codes. I built a coding scheme, and then I piloted that coding scheme, and I went back through and I recoded again with an open coding as well with a coding scheme. I built a master coding list, which I then was able to do open coding along with the master coding list on each of the subsequent transcripts. This process continued until all of the transcripts were coded. I then moved into a little bit more of a deductive and a theme creation. I looked back at my questions and I made sure that I had I was developing themes that were really answering my questions. And so then I was able to categorize and code my data across the sources into these themes. Of course, prioritizing and restructuring those recurring patterns to answer my questions. And these are the findings. These are preliminary findings. So looking at the question of the parent role. So what is the parent's definition of their role? How did they see their role during these processes? This was an extremely important question to parents. I had some really thick, rich information that came from my participants in regards to this question. They really felt that it was unclear. They were confused. They felt that they had a different sense of their role versus what they felt the school district thought that their role was. So they felt that there was a dissonance there. Collectively, the participants wanted to be included and supportive of the process, but moreover, they really wanted to be informed. They felt that they lacked a basic foundational knowledge of the information on what was going to happen, what the process was, and they felt lost. Participants also shared not knowing who was going to be assessing their child. They wanted to know the specific person so that they can have conversations with them. They could know what was going on, and so that they can prep their child. They felt at a loss for not being able to help their child with what was going to be different for their school days coming up. The next theme was for parents' rights, and this is the procedural safeguard question. All of the participants mentioned that they did get a copy of their procedural safeguards. The majority of participants shared that the school districts did not give an explanation, or that the explanation was cursory or not in great detail. The majority gained their knowledge of their rights from family resource centers. And this was a theme that I seen throughout the entire interview process and data collection process. 3 of the 5 participants shared that either they didn't know anything about their parents' rights, or that they felt knowing all of their rights was not important at that time, and were not able to articulate what their rights were. The next theme that came out was their understanding. So the bulk of their understanding of the IEP process, as well as assistance with the law, the Individuals with Disabilities Education Act, came from family resource centers. Participants also created their own self-advocacy skills, they credited their own self-advocacy skills with seeking out information from multiple sources. They had talked to other parents, they had consulted the internet, and they reached out to family resource centers. An overwhelming credit, like I'd already mentioned, was given to the family resource centers for their level of support and advocacy throughout the beginning processes. So that was prior to the assessment, during the assessment, and during the actual IEP meetings. 4 out of the 5 participants utilized family resource centers to help them get through this initial phase of their special education experiences. On the opposite end, an overwhelming theme emerged in terms of the lack of support and information that was given by the school district as a whole. Something that was of interest to me was after students qualified. So this is pretty lengthy process for the majority of the parents, up to 2 years. They had fought to have their child assessed, and they eventually qualified for special education. So this theme was prevalent, and it was important, and it was emotional and very powerful in the data that was collected, and I wanted to share that with you guys. The participants, they noted that once their child had qualified for special education and they had moved through that initial IEP meeting, so now they're qualified and they have an IEP, they felt that the subsequent meetings that they've held with the school districts have improved. So that was good. It was also notable that 3 of the 5 participants described a positive and even supportive relationships that was built with the school districts versus only 1 in 5 prior to this process. I can picture each and every one of the participants, and at the beginning of the interviews, they were grim and they were sad and they were emotional to the point of tears at some times. And towards the end, when they were describing the relationship that they were finally able to build with their school districts and their IEP teams, it was powerful. The message for me still is in that information in the beginning. The 2-year struggles that were described, the lack of information and the lack of support. I am working on a second article in which I will be utilizing the barriers and the suggestions that was given during this research project to help move that forward for the parents and to bridge that gap for school districts and parents together. Any questions?
Good morning. I'm excited to be here. I'm not excited that the pollen came, but just hopefully you'll be able to hear me throughout this whole talk. I'm excited to talk about our study that we did looking at patients that were admitted to UC Davis over a 2-year period, all patients who are admitted with intellectual or other neurodevelopmental disabilities in acute care, and we focused on their outcomes and costs. This was a nursing research team. Last year, the long-term Len Fellow Shannon began the process of trying to collect the data from UC Davis. If anyone's tried to get EMR data there, it takes a little bit of time. So I joined this year working with our mentor, Diane Baker, and we continue to work and analyze the data. So the reason we wanted to do this is for two reasons. First, on the patient side. So patients with intellectual and other disabilities have more frequent admissions. They have complications in the hospital stay. They're more exposed to patient safety outcomes. And so as nurses, we are really looking at the factors that affect their hospital stay. But healthcare providers, on the other hand, we're not really given a lot of education specifically on, or training specifically on, people with intellectual and disabilities, especially in the adult general population. And so patients and families pick up on this, and they feel like that healthcare providers are not always trained for this specific population. So that was our purpose, to provide a demographic and descriptive analysis of patients with ILD that was admitted to both the emergency room and UC Davis Medical Center for a 2-year period, so 24 months of data from 2015 and 2016. And out of this, we want to design an educational intervention for healthcare professionals. And so the long-term outcome of that educational intervention would be to improve safety outcomes. So our data set, we got it here, UC Davis Med Center. It was 24 months, and it included all the emergency visits, admits, and acute care hospital admissions. We used words to try to get people with ILD, so developmental delay, autism, seizures, and got 27,133 original data points in their data set. Now, a lot of that was the word seizures. Sometimes that was the only indication that someone had ILD in the data set, but that also gave us a lot of pieces of data that were not developmental delay. That was another type of seizure disorder. So going through that individually, Dr. Baker, we got 13,288 that were ILD cases. Of 1,133 patients. So there's a lot more lines for each of those 1,133 patients. That was all of their admission, or all of their diagnoses during the hospital stay. So anytime you lovely physicians put a little record in there, it showed up as a data point. So our sample, this was the full sample, was ranged in age from 0 to 93, a mean age of 14, and about 45% were female, and the race and ethnicity was a little over less than half were white. 24% were either other or didn't specify. We have about 15% African American, 10% Asian, and this data set didn't. Besides those that identified as Mexican American, there wasn't a Hispanic or non-Hispanic and information in this data set. And then where they were admitted from, about 600. So half were from the UC Davis emergency room, but another 200 were transferred from a different emergency room, 130 physician and some clinic referrals. And we have some newborns as well that were born in the hospital that had ILD. The average length of stay, again, this is the full data set, ranged from 0 to 269 days because we included the same day admissions and discharges home from the ED. And so that was an average mean of 5 days. 35% were admitted to the ICU with a mean length of stay in the ICU of 10 days. And so then cost. So the cost mean of payment, the payment was $31,000, which ranged from 0 paid to $2,400,000, and the total charges was a mean of $150,000 for our patients with ILD, ranging from $300 to $10 million. It's painful to even say. So the admission diagnoses most common was seizures, even after screening down for those that didn't have, that were only seizures with an ILD disorder. And then agitation, paroxysmal spells, developmental delay, and cerebral palsy were the most frequent primary diagnoses. And then the chief complaints or the other diagnoses for their hospital stay were most often seizures, hypertension, urinary tract infection, acidosis, and trauma. So we did a subset of patients that were just 18 plus, just the adults, and the ones that were not discharged the same day from the ED. So these were the subset of adult patients admitted to the hospital. And so there's 249 in the 2-year period. They were about 46% female, and now our age range is 34, 18 to 93. Mean length hospital stay was about 7 days. 24% were admitted to the ICU and stayed in the ICU about 9 days. So we looked at the subset of admitted adult patients to the hospital to look at some other diagnoses that might indicate the safety in the hospital stay. And about 5% of the admitted adult patients developed sepsis, and 9.6% had pneumonia. And that is interesting, worth looking into more, because the national rate of adult patients that develop pneumonia is 1.6%. 2.8% had dehydration, which is higher than the national rate of about 2% of adult patients. And 3.6% had restraints used during their stay. So the implications of this, had over 1,000 patients submitted with ILD to UC Davis over the 2-year period, and they have unique and specific needs. But nurses, especially on adult units, don't get special training to care for patients with ILD. And these secondary diagnoses are really concerns, especially the higher rates, to look at for patient safety. And then there's the issue of the newborns that are diagnosed with ILD. Currently, there's limited use of care coordination that translates into the clinic system. So when they're in the hospital, they're great care team in the NICU, but we're still refining how that translates when they're discharged. So limitations of this. This is a preliminary analysis of the data set, and it's probably underrepresented because not everyone puts down if they have diagnosis of an IOD, they don't always say it in their medical record when they're coming in. So that's why we looked for seizures or other disorders to indicate it. It included, the major data set included ED same-day admission, so it wasn't all acute, it wasn't all people that were admitted, except for that. So we're going to look more at the subset. And then there was challenges with the not present on admission codes. They were being inconsistent, so it was hard to identify. For the complications, things like pneumonia, was pneumonia at admission or developed after? And then I already mentioned the issue with the seizure diagnosis and the various names and labels used in the EMR for the same thing. It was hard to really define that. So what we're going to do next is we're further refining this, going through and doing some more analysis, and we're going to establish courses, educational courses for healthcare providers. We're going to beta test classes at UCD and already made connection with the nurse education department there to start our classes for potential nationally distribution to really focus on the patient safety for adults, for all ages admitted with IOD in the hospital.
So thank you, yes. Again, I'm a child and adolescent psychiatry fellow, graduating in about 6 weeks. So that's exciting. And my talk today is on the prevalence of bullying in typically developing children and children with autism and/or ADHD. So first off, what is the CDC definition of bullying? Bullying is any unwanted or aggressive behavior by another youth or group of youths that are not siblings or current dating partners, involving an observed or perceived power imbalance. And it's repeated multiple times or has the possibility of being repeated multiple times, and it may inflict harm or distress on the targeted youth in a psychological, social, or educational or physical way. And any young person can be either a perpetrator, a victim, or both, which I'll refer to as a bully victim. So this poster was at my daughter's daycare, and I thought it pretty well summed up bullying for a young child to understand. Obviously, it didn't go into all the other CDC definitions of it. But it said when someone does something unintentionally hurtful and they do it once, that's rude. If they do it something intentionally hurtful and they do it once, that's mean. But if they do something intentionally hurtful and they do it multiple times over and over again and they know that it's upsetting to you, then that's bullying. So I thought that was a pretty good representation for a second grader. So then we also have to talk about cyberbullying. Cyberbullying is the bullying through the use of electronic devices or social media. And why is it different? So essentially, cyberbullying can be anonymous and distributed quickly to a wide audience. And it can be difficult at times to even know who put it up, to trace the source. And it's really difficult to delete that information once it's out there. And the children have a harder time getting away from the behavior. So it can happen 24 hours a day, 7 days a week, often when they're alone, which is really troubling. So what do we think we know about bullying? So when it occurs, most bullying typically occurs during or after school. So even when you include the cyberbullying, this is when most of the bullying typically occurs. Where does it happen? It happens mostly within the school building itself, but it can also be on the playground or traveling to or from school, but mostly it's within the school building. It could happen in neighborhoods as well and on the internet, such as cyberbullying. And the frequency, according to the 2014-2015 School Crime Supplement, about 21% of students aged 12 to 15, just general population, experience bullying. And according to the 2015 CDC report on Youth Risk Behavior Surveillance System, 20% of students within the last 12 months on school campuses from the grades 9 through 12 experience bullying, and of that same cohort or subject sample, about 16% of them reported electronic bullying. So essentially, the takeaway is about 20% of youth experience bullying in some manner, and that's general population. So what can bullying affect? We know that it can affect an increase in anxiety, depression, sleep difficulties, school problems, and we know that youths that bully others have an increased risk for substance use, academic problems, and go on to have issues with violence later in adolescence and adulthood. We know that bully victims are at a greater risk for both mental health problems and behavioral problems. And the most important thing that is a take-home for me is there is an increased risk of suicidal thoughts and suicidal thinking. So who's at risk? Anyone that's different. Anyone that's perceived different from their peers. So someone in the LGBT community, weight differences, anyone with a disability, or as someone that's perceived as weak or has low self-esteem, children with mental health issues such as depression, anxiety, and essentially there's also a subset of those who don't really get along well with others, that seem annoying or provoking, or that antagonize others. And so a lot of our kiddos with ADHD kind of fit into that section. So the existing research on bullying in ASD or ADHD are as follows. So children with ADHD are more likely than others to be bullied, according to these research studies, and they're somewhat more likely to bully others. And one study put the prevalence rate at about 28%. So that's compared to that general population of about 20%. And in autism, in one study of 18 to 17-year-olds, again, I'm trying to get over to my things. Researchers found that children with autism were more than 3 times as likely to experiencing bullying as their peers. And then in another study, it had the prevalence rate at about 40%, but it seemed to be moderated if those children had ADHD. So in light of these mixed results, I decided to do my study. So the purpose of my study is, given that the overall prevalence of bullying is about 20% in students ages 12 to 18, and there are indications that the prevalence of bullying is higher in children with ADHD and or ASD, I hypothesize that the prevalence of bullying is actually higher in children with autism than with ADHD. So what did I do? The CDC has a wonderful compendium of assessment tools for bullying. They're just aching for people to do research on bullying. So they provided this. It has 33 measures that are divided into bully only, victim only, and bully victim measures. And they provide various rating criteria for each measure: inter-item correlation, alpha coefficients, retest reliability, and they break them out that way. And then they provide a rating of each as exemplary, extensive, moderate, or minimal. So my method. So I chose 2 different scales from the compendium. The first was the victimization scale. It's a 10-item measure that assesses the frequency of being teased, pushed, or threatened in the last week. It targets ages 10 to 15. It received an exemplary rating. And an example question is, during the last 7 days, a student teased me or made me angry. And then the child circles on a scale of 1 to 6 plus how many times in the last week that occurred. The second measure is the adolescent peer. It's a 36-item measure, and there's 6 subscales on it. The frequency of, it assesses the frequency of physical bullying, verbal bullying, social bullying, and it separates it into perpetrator and victim-only scales. It targets youths 12 through 17. It also received an exemplary rating, and a sample question is, since you have been at this school this year, how often have you done the following things to a student? Made rude remarks at a student. And it's answered on a scale of 1 to 6. 1 is correlated with never, and then it successfully goes successively goes down to sometimes once or twice a month, once a week, several times a week, or every day. I received permission from both of the authors or generators of these scales. My subjects. So 2 different sets of subjects. I have patients with diagnosis of ADHD and or ASD being treated at both either the UC Davis Children's Behavioral Health Clinic or the Mind Institute ASD and ADHD clinics. So they have a documented diagnosis. And I also have typically developing subjects through a public middle school. So my current progress. I went through the IRB approval process and a modification because one of my parental consents when I was working with the school, they agreed to the process, and then we were going back. They said, no, let's do a passive consent. And then so I did a modification and ended up with just having to do a parent information sheet. So that was really kind of nice. That helped things. My data's all collected. I have 49 subjects with ASD, ADHD, or both through the clinics, and I have 714 typically developing subjects from a middle school. I originally was planning to get another set of typically developing subjects from a high school, but the scheduling issues made that impossible. I have REDCap access has been granted, and I'm in the process of developing and testing my database and entering all those 700 some odd surveys. And I've met with and I plan to analyze data with the gracious help of Anna Maria Iosif. And I plan to present all my findings at the psychiatry poster presentation on June 15th. And I really want to thank Anna Mudd over in the Massey Clinic because she helped me distribute the surveys, and all my fellow residents and because we came together and they distributed surveys as well. And of course the LEN team, it's been wonderful. So any questions?
All right, so I'm Patrick. I'm here to talk to you today about translating scientific research to the community. So science is a wonderful thing. It allows humans to understand the world and the universe around them. Every day there are discoveries being made from new quantum particles that could give us clues as to the nature of space and time, new biological techniques that could change the face of disease treatment, new exoplanets that may contain life beyond our small pale blue dot. It may seem like after the difficult aspects of scientific discovery, from grant proposals to the actual implementation of your research to writing manuscripts, after all that, you're home free, right? Wrong, it's a trap. So how do we get all our information out there to the community? How do we do it in a way that benefits our audience? So I was at a talk the other day by an SLP. It was on speech and language, of course. I'm a pretty smart guy. I know nothing about speech and language. I've referred SLPs. That's about all I got. So when this slide comes up, I'm like, whoa, lots of words, lots of concepts, and I am confused and done. All the words are, simple English, but when you put them together in the context of speech and language, I got nothing. So as the speakers continue to talk and go through slides, I'm stuck on the first slide, still wondering what the P in SLP means. So today, we're going to be talking about, again, translating scientific research to non-experts in the community. We're going to talk about orienting your perspective, and then we'll talk a little bit about attention, and then brain organization, and then I'll give you some tips as to how to address those different domains. All right, so orienting your perspective. First thing I want you to ask yourself is, who is your audience? In our case, it's going to be non-experts, of course, but what does that mean? You know, could they be reporters or advocates or philanthropists that you're trying to get money out of? Maybe they're families, you know, parents, siblings, dogs. Maybe they're other scientists in other fields, whether related or not. So the answer to these questions are going to inform how you approach your presentation. The next question, what are the skills of your audience? Are they all complete novices? Are they Padawans? That is also going to inform how much detail you can get into. Next question, what is their motivation for being here today? It could be some scientists in other fields who are just looking for general information about psychology. It could be parents that are looking for a little bit better understanding about their child. Or it could be a client who's actually looking for interventions or personal help. And then the last question, which will also inform their motivation, is how was their day? Is it morning or night? Did they have a fight with their spouse? So let's pretend that this brain is from your audience. Maybe this is a woman who had a long day at work. Then she had to drive to her child's school to go to an IEP meeting. And then she had to drive through traffic to get to the Mine Institute to this presentation and find parking, which obviously is terrible. And then she's got all these things flying through her brain. How do we break through that and get our information, in there? You're looking at the cats, aren't you? Exactly. All right, so how do we grab attention? First, I want you to eliminate extraneous and excessive information. I want you to pare it down to the nitty-gritty, or not the nitty-gritty, the bare essentials. So too much text, not spelled correctly, obviously, is going to put me to sleep. Try to use some metaphors and analogies that are relatable to the community. So say I'm talking about macrophages. It's a cool graphic, but what if I said that a macrophage was kind of like Pac-Man? He likes to grab foreign microbes, which are the ghosts, and and then he processes them and maybe gives them to his wife, Mrs. Pac-Man, the T cell. So which method is going to allow your audience to remember what you're talking about? I don't know, you decide. So use of visuals and fonts, colors and animations are important, but of course, don't overdo it, like I might have. So take a look at this slide. It's got some colors, cool, but the fonts are way too small. It's hard to read. And black on red background is really hard to read. And then the color scheme is kind of non-congruous. What does red mean? Often red is danger or caution. So why is the elementary school and the volunteer coordinator red? I'm not sure, but I've got a bad feeling about them. Okay, so for more complicated processes or information, you might need to go step by step and walk your audience through it. So again, with the macrophages, you're going to have to go through each of these steps and explain a little bit about them and maybe make some analogies like our Pac-Man or Mrs. Pac-Man analogy. And then this is a big one for me, jargon and acronyms. I can't tell you how many times I've gone to a presentation and the author throws up some acronyms and random jargon, and I am completely lost on slide number 1. Where did it? Oh, there it is. So when I see this, I shut down and I can't leave because that's rude, but I'm not paying attention. So cut down on that jargon. I know we all kind of live in as experts, I'm not an expert, but you are, and we live in a field where we just immerse ourselves in the jargon of our expertise. So when we get out to impart our information to the public, to the community, it's really hard to step away from that and actually talk like human beings. Also, tell a story or two. Like your kids, they really benefit from hearing a social story to get them through particularly difficult concepts for them. Same thing with your audience. A story can evoke feelings and emotions that can help you get your information out there and have them remember it better with an emotional state rather than just data points. And minimize reading from the slides and limit the bullets. Of course, I have a lot of bullets, so it's a little ironic that I say this, but I cut it with a little Pac-Man, so it's cool, right? Okay, so let's talk about brain organization. So I research Fragile X. I've been doing it for many, many years. So this closet is kind of like my long-term memory. It's all very organized. I've got my molecular on one shelf and my clinical correlates, over on the other side. And every time I get new information, I can easily integrate it and process it and put it into the correct location on its proper shelf. But when I first started Fragile X research, this was my brain. Basically, molecular was taped to the wall, behavior was under that pair of pants. You know, I had interventions and clinical correlates under all this detritus in my head. So when I get a new information, I have to go digging for the concepts that I've previously learned, and it's going to take me a lot of time, a lot of effort, and a lot of energy to get through that. Of course, that Papasan is nicely organized, so that's where I keep my Pokemon characters and Disney songs. All right, so how do we address that brain organization of your non-expert client? Sorry, not client, audience. So we can integrate text into graphics. So remember that horrible pie graph. So you have to be scanning left and right, trying to put a title to each one of these little pie slices. But what if we put the titles next to the slices? It's more easily digestible, and we can quickly move on to other topics and build upon that knowledge. Next, again, use fonts, coloring, and animation to show importance. So if you look at this slide, larger fonts means better, more important. The color scheme is great, except for the front is hard to read because yellow on white is not good. But colors can evoke emotions, which will better help your audience to remember. So green can indicate money. So for a business presentation, it would be appropriate. Or it can also indicate nature, which would be good for maybe fuel efficiency standards or something like that. And then try to be clear and simple versus clever or pretty. I mean, if you can do all four, awesome. But clear and simple is better. I mean, is what you want. So if you look at this graph, it's separated into 4 quadrants. The colors are congruent with the feelings that they evoke. So red is threats, blue is strengths. So it's easy to understand. This is another similar slide, same topics, but the colors are more prominent. So when you go onto subsequent slides, you can have a background of blue, and your audience will already be primed to think that strengths are coming. Okay, often we have all this stuff that we've done. We've done presentations, we've done posters, we've done manuscripts, and then we have to do a presentation really quick. So we cut and paste, we throw it in there, and we're done. Wrong. Don't do that. Try to make it a flowing whole so that it tells a story to your audience and leaves them with something to remember. And then finally, if you have to give large amounts of information, try to chunk it into smaller, digestible pieces. So for example, if I were to give you a recipe, this is a lovely recipe, it's yummy, but as I read through this, you're gonna be sleeping in about 37 seconds. But if I chunk it, I can first in the first slide, go through filling ingredients, next crumble ingredients, and then go through the directions in several slides. Okay, so in summary, did that go? Yeah. Okay, so I talked a little bit about translating scientific research for non-experts, including the community and families. So we talked about orienting your perspective. We talked about attention and brain organization. And I gave you a few tips. There's a lot more out there, but how to address those issues. And I would like to ask you if you have any questions.
Good morning, everyone. So my topic is community outreach, program development and engaging underrepresented parents in group therapy. Why is it important to work with parents from the underrepresented population? As many of us know, children and families from ethnic minority backgrounds are less likely to engage in services, and retention in parent training programs is lower among parents and families that are in ethnic background, minority backgrounds, or low income households. This population are also more likely to experience diagnostic delays for developmental, social, emotional, behavioral disorders, and that can interfere with timely and sufficient services. Improving parent engagement for at-risk families would likely lead to timelier treatment access and ongoing participation in services. So my objectives for my project was doing a needs assessment to develop content and engage parents, develop a parenting group and content that fits the needs, assessing the parent knowledge about autism, and assessing parent empowerment. So a little bit more on each one of these objectives. We partnered with a nonprofit organization called Cerna Village. Cerna Village provides low-income or temporary housing to families that are homeless and are committed to a life change. And with this, our goal was to meet and develop a parent group, develop this material based on their needs. So I completed a needs analysis. We did an initial meeting before, and 4 parents showed up. And the general themes that were captured were general parenting skills, how to manage challenging behaviors, and self-care skills. They also determined that meeting weekly is not going to be the best for them because they were worried that they wouldn't be able to show up each week, and monthly would probably be most effective. So we determined a monthly meeting for about 90 minutes, 6 sessions total. And the topics that were developed based on their requests and their needs are the different types of parenting styles, like authoritative, authoritarian, talking a little bit about how our brain is wired to parent the way we were parented, which is always a fun discussion. Positive parenting techniques, catching your kids when they're being good. Understanding behavior, the ABCs, the function of behavior. Managing challenging behaviors. And then a deeper dive into managing challenging behaviors. I also added to the self-care topic is self-management skills, because during session 1 I did and we're going to talk a little bit more about assessing the empowerment scale of the parents, and self-management skills was one of the lowest scores on there, and so we'll talk a little bit more about that, but that was also added. So objectives 3 and 4, assessing parent empowerment and knowledge. The parent empowerment scale was a Likert scale, 1 to 5, from never to very often, and it was completed during session 1 of the parent group. And to give just a little bit more information, It's really assessing the confidence of the parents for their own parenting, their family dynamics, and also that their confidence in advocating for their child services. 5 parents participated in the first session, pre-questionnaire. I'm sorry, I don't have post-questionnaire results yet. We're still in process of the parent group. 3 out of the 5 parents had a child with either ASD or ADHD. So I was quite impressed with their overall basic knowledge of autism. It was nice to see that they scored about a 78%. Their lowest score, or a common question that they were not familiar with, was, is there a single best treatment for autism? But for the empowerment scale, parents self-reported it's 3.5 out of 5, which lands between a sometimes to often, regarding feeling empowered overall for their family members and their parenting skills and their family dynamics. And parents reported often to a very often regarding feeling empowered of their child services. Some areas of improvement to focus on when I was developing the material and the content was some of the questions was in regards to about their own parenting, and it was when problems arise with my child, I handle them pretty well. And so that's why self-management skills were incorporated into the content. And then about your child services, the lowest score was, I know how to get agency administrators and legislators to listen to me. That's a tough one. So post results will be used to evaluate the effectiveness of the training based on parent attendance and the knowledge of autism, if it increases, and if their empowerment, feelings of confidence does increase. So adaptations. There was a lack of research trying to find strategies on how to engage. So we know the research that their parents are less likely to be in parent training programs, these at-risk families. But there aren't strategies or research or material really of how to make these changes. So parent attendance and parent engagement is definitely a complication. After session 1, so during session 2, no one showed up, not even the administrator of the Cerna Village, and I thought, oh, what is going on here? And it made me go back to making some adaptations. We talked about what are some of the things that we can adjust to engage and really make this a good fit for the parents that have so much on their plate and trying to make major life changes. And so it was having many more reminders from early in the week to the day before through their social media sites where Cerna Village communicates with them in that way. Providing snacks. I go to an Italian bakery, and I thought if Italian baked goods can really might make a difference for parent engagement. It makes a difference for me, so. And then we do a little raffle where Cerna Village provides tickets to either a $5 gift card to Starbucks or some sort of household item, and we've seen that really made a difference because session 3 and 4, everyone showed up. A lot of these strategies, it was really nice for me to see that we not only do we need to constantly be conscientious of the content for it to be a right fit, but there needs to be a little bit more than that's involved to really reach this population. I have an interest in minority mental health, being Middle Eastern myself, and I put on a parent session in the community and at the local library for free, and it was an interest of mine, and I took a lot of these strategies of engaging this population, and I made lunch, and 45 people showed up. So it was really nice that so many people attended for a Middle Eastern parenting session where I used a lot of this information with the reminders, how to market it, and some of the ways to get them to show up.